Very good morning to everyone here. It's good to see that other than speakers and the panelists, some more people are also here. Happy to see all of you here. First of all, on behalf of Glaucoma Society of India, as a president, I would like to really thank the KSOS for this great opportunity. And I'm happy that we have started our GSI activities in every state conferences. And we have a theme for every year, at least for next couple of years we have a theme. This year it is all based on the case presentations and discussions by the panel. So every state is conducting now the same theme this year. So soon we'll have the next meeting coming up, we'll have a different theme. So thank you all once again, and we will start the session. We have clinical case presentations. It looks like only we are going to discuss on each other. So I'll just hand over the mic to Sweta now. Sweta will coordinate the session. Over to you, Sweta.
Thank you, sir. Good morning, all. Now, I would like to invite our panelist. We have panelist Dr. Sai Kumar, sir, who is our past KSOS president, and he's from Giridhar Eye Institute. Dr. Thomas George, sir, sorry, from Chaitanya Hospital, Trivandrum. Dr. Bindu ma'am from Contrast Eye Hospital, Calicut. Dr. Girija ma'am from Little Flower Eye Hospital. Dr. Meena ma'am from Chaitanya Hospital, Trivandrum. Dr. Manoj sir from Amrita Hospital. And Dr. Kiran Gopalakrishnan sir from Princess Eye Hospital, Trivandrum. And we have our 5 case presentations. I'll be presenting the first case. I'm Dr. Shweta from Jyoti Sai Care, Kannur. Second case will be presented by Mahesh Bharati. Dr. Mahesh Bharati is from Ahalya, Palakkad. Dr. Nimita Najib from Contrast Eye Hospital, Calicut. Dr. Lita George from Tony Fernandez Eye Hospital, and Dr. Manju from Arya Eye Hospital, Thrissur. Dr. Satin sir will be moderating the session. I'll start my presentation. So we have 10 minutes for each case presentation. So can I have the timer for 10 minutes? Thank you. Now I'll start with my presentation. We have a 59-year-old gentleman who came for a routine eye checkup. His past ophthalmic, there is no past ophthalmic history and medical history. He is a hypertensive and hypercholesterolemic for 5 years. There is a family history, mother and sister have glaucoma, and in personal history goes to gym, do weight training, yoga, and drinks about 750 ml of water at a time. Visual acuity best corrected in both eyes 6/6 and N6, and intraocular pressure at 5:13 p.m. was 16 and 18 by applanation tonometry. Anterior segment examination was within normal limit. Gonioscopy, we had an open grade 4 angle. Fundus examination with 90D wide field lens, we see that both disc had a cupping of 0.5 to 0.6, and central corneal thickness was 580 micrometer in the right eye and 584 in the left eye. This was his fundus photo. You can see that both eyes, there is a cupping of about 0.5 to 0.6, and there is slight asymmetry between right and left. If you see in the left eye, there is a slight suspicious thinning of the NRR, early thinning, with the suspicious looking slit RNFL defect there, which is seen in the red-free image too. And the visual fields were done with Octopus 900 G-dynamic program. You can see in the left eye, there are a few areas of depressed sensitivity in the inferior field. And Bevy's curve in the right eye looked normal. In the left eye, even though it is in the normal range, you can see that there is a dipping, early dipping here. and the polar analysis and the cluster analysis, there is a slight suspicion in inferior field. Now coming to the optical coherence tomography, which was taken in the spectralis, segmentation was confirmed, and this is the right eye, which showed a normal MRW, RNFL, and the GCL, and there was no hemisphere asymmetry. And in the left eye, we can see that there is a temporosuperior thinning in the RNFL, but the GCL looked fairly normal. And the deviation map in the right eye looked normal, and in the left eye you can see that there is a slight thinning of the RNFL superiorly, but GCL didn't show any changes, only very early change. And we did the diurnal variation test from 8 a.m. to 4 p.m. And the maximum IOP was 18 millimeter and 13 millimeter, minimum was 13 in the right eye. In the left eye it was 19 millimeter and 13, so there is a difference of 6 millimeters in the right eye. And water drinking test was done with a baseline of 13 millimeters of mercury, and the values, the baseline 30, the maximum was 20, the difference is 7, and in the left eye 13, 22, the difference was 9. And at the end of 60 minutes, the left eye didn't come back to the baseline. It remained at 20 millimeters of mercury. Electroretinogram was done, and you can see that in the right eye, the PERG waveforms were normal. In the left eye, even though it gave a normal pattern, but still a slight depression was seen. And even the magnitude and magnitude D ratio also showed a little bit of depression. The PHNR latency was 76 and 78. So in this case, whenever you have a glaucoma suspect, we have 4 phases of examination. The first phase is history, slit lamp examination, and CCT. Second phase, anatomical and functional damage. Third is the fluctuations in IOP and outflow compromise. And fourth is measure of cells under stress. This case I had put forward to have a discussion on what next to do, whether to actually treat this patient or can we just observe, because we have only suspicions. There is no definite indication of damage. So the case is open for discussion.
Shall I?
Yeah, sorry. This is a very interesting patient actually. He's, I won't say who he is, but he's one of the VIPs. But how will you manage this patient now? I know the in and out of this patient now. Yeah. Sorry, sir.
Why do you say it is suspicious?
Yeah.
Too many points favoring the patient goes into the spectrum of glaucoma.
You have a defect, clinically you have a small dip there. You have a corresponding RNFL defect. Same thing shows in the OCT, and the field also shows an early change. So, and why should you classify it as a glaucoma suspect?
Okay. Elaran Cholang, I mean, after all of you, just tell your points, then I'll just.
There is an RNFL defect, and the water drinking test is just beyond. I mean, 6 would be the acceptable thing. It's just outside, and the left did not come back as this thing. So left eye probably is at higher risk, is what we can say. He's a person at risk. You can call him a suspect. I wouldn't treat. I would keep him on a close follow-up. Maybe 6 monthly.
2021?
Yes,
22
sir, it was
is
2021.
you can call him an OHC with that water drinking test, but the baseline we've got 18 as the first this thing. Yeah, that's one risk factor down, but we would still keep him on follow-up. I would be very cagey about starting treatment.
Right. Any other?
Looks like feels like it's more like an episodic kind of, maybe his gym practices with water drinking over a period of time must have created a small RNFL damage, but it's very difficult to consider treating him, because even if we look at all the parameters, assume that the patient has had a defect.
Given the family history?
Yeah, family
has a
history is
family
also
history,
there.
mother
So
and
it looks
sister.
like at best maybe something like a normal tension glaucoma.
So
Most
mother, I have
likely.
operated both eyes trab. I mean, combined surgery I have done in 97. Sister, both eyes I have operated.
That makes a little.
Does this change your decision now?
I think
They're just next door to the hospital.
I think I would.
Very known person VIP, so obviously a follow-up is not an issue.
Yeah, yeah.
Even then I would treat.
can go for genetic evaluation, but is it really required? But mother,
How does it change
mother
your
is
management?
Mother is. I have a very small thing in this. Mother is 0.9 both eyes, and the sister is also 0.8 CDR.
Visual defects, sir. So sisters,
Yeah,
sisters visual field test.
that is exactly where I was trying to come to. So ever since 1997, mother, though the IOPs are maintained somewhere around 17, 18 post combined surgery, even today the visual fields are the same. There is no change in the visual fields. She is not on any medication, though we know per 0.9 we can expect the progression to be there at 18 or 19 IOPs. Sister 0.8 having 0.8, absolutely no progression for the past 20 years. Sister is also post-trap, but all of them having an IOP of 18, 19. Why I am particularly saying this is, for him also I am been observing, this is very easy to miss this RNFL loss, though it looks easy to pick up in the fundus photograph. But when you really see with your 90D in a small, say 3.5 mm or 3 mm people, we can very easily miss this RNFL loss. See this loss.
But again,
But
it's only a slit defect.
That's a very slight defect. He is the same for the past many years. He has not changed, though his other things are showing up on the positive side, saying that okay, the IOPs are slightly on the higher side, there is a definite RNFL loss, everything is there, but this is a question whether to treat or not to treat.
The sister and mother were operated for high IOP or?
Yes.
Yeah, obviously because IOP levels are higher rather than progression was there.
Yeah, in spite of their being in 18 and 19 for the past 20 or 25 years, they have not shown up any, post-trap, they have not shown up any progression in spite of an advanced glaucoma. What I am saying is, when you have a target IOP in the advanced glaucoma, say 10 to 12, and they are always on 19, around 18, 19, 20, in spite of that, both of them have not progressed. So it is a very slow disease, that is what I am trying to say. Even for him, he has crossed 60 plus. It is not very old age, but we have to be a little bit more cautious in over treating the patients. Suspects, we can kind of suspect, this is definitely a suspect, I will put it as. We can keep on observing him as he is very close by. He can come to check up at any point in time. So I wouldn't treat him very aggressively at this point in time. Because
we can tell him about his gym practice and drinking too much water.
yeah.
Lifestyle modifications. Okay.
Only thing that we have told him, so he is not doing any kind of upside down exercises and he's not lifting the weights now. So his IOPs are maintained, his fundus is the same, absolutely the same. There is no change in the visual fields it is very difficult, small defects. What I'm saying, it's very small defect, but follow it up with other family history is also very important. The progression of glaucoma has to be seen as a in toto. It is not that you just take one patient, but if he has other habits of whatever progression, we have to be a little bit more careful. But showing up the family history in this is very important. Understand that not every patient has a fast progressing disease. So categorizing the disease into fast progressors and the slow progressors are very critical for us. Thank you, Shweta. So I can call upon the next. Any other points that you want to add up in this? So what is the other thing is doing the electrophysiology of doing the pattern ERG and photopic negative response gives us a clue that the cells are really under stress. For him it looks like very minimal change, but I won't say this particular ERG has given us a great clue whether to treat or not to treat, but we can just observe and then we can repeat the PHNR to see whether there is any change. So that also can guide us whether to treat or not to treat. It is not only the other parameters are important, but that also can give us some idea.
It also underlines why we need a fundus photograph. We need it for follow-up to look at the previous photograph, and this is a subtle change which may miss.
Very easy to miss. Very easy to miss. Not our regular cameras will pick it up. This is a, what do you call?
SLO.
Add-on. So what is the technology?
SLO, sir.
SLO, yeah. SLOs will easily pick up, but non-SLO cameras might pick up, might not pick up, but just be careful whenever you are seeing the fundus photograph, are you able to see all the RNFL properly or not? Yes, Shweta, thank you.
Next, I call Dr. Mahesh Bharati for his case presentation.
Good morning, everyone. Thank you, Dr. Satyan and KSOS for the opportunity. So, moving ahead from the spectrum of glaucoma suspect, we'll talk about a case where we managed beyond IOP control. So, we have a 42-year-old female presented in December 23. She came for a second opinion. She was seen the same day somewhere else and was told to have glaucoma and was advised to start on AGM. No family history of glaucoma. No other significant history. On examination, her best corrected visual acuity was 6/9 blur because she was pharmacology dilated, and both eye had a cortical cataract of CC grade 2. Intraocular pressure by applanation tonometry was 16 and 14 millimeters of mercury. Central corneal thickness was 510 and 520 microns. Fundus showed a right eye medium-sized disc, a healthy disc with a healthy neuroretinal rim and a cup disc ratio of 0.4, and retina was on. Left eye showed a medium-sized disc with a cup disc ratio of 0.6. Inferior rim was thin with a disc hemorrhage and a well-defined RNFL defect, as seen here. We did a single field analysis. This is a 24-2 field. And essentially, if you look at the parameters, glaucoma hemifield test, the VFI, everything almost feels like normal. So I would like to ask the panel, what next? How do we move ahead with this case?
The only positive finding you have is a
We have
disc
a disc
hemorrhage
hemorrhage, and there is no other
in an
significant
otherwise
history.
normal looking disc.
Yes, yes.
You have to look at other. How old is this patient?
The patient is 42-year-old.
42. 42 is not a very common age for a routine disc hemorrhage to be seen.
Another
Yes.
thing, there appears to be a continuous wedge defect.
Yes, ma'am.
contiguous
Yes, ma'am.
with
There
the
is a RNFL
hemorrhage.
defect
Yeah.
underneath that. There is
That
a
may
very
carry some more significance.
well-defined RNFL defect underneath that. CCT is 510, 520
Almost normal
microns.
to thin,
Yes.
slightly.
Okay. What next after this visual field? Do we?
Yeah, the faster.
You got a wedge defect.
Yes.
You got a hemorrhage next to it, suggesting that there's going to be a progression.
Yes.
And you actually got subtle field defects here corresponding to the wedge defect.
Yes.
You already have a diagnosis.
Yes.
It is a glaucoma. Now the question is whether it's an NTG or whether it's a genuine NTG or a high pressure glaucoma.
Yeah.
Any whichever way, I would feel more comfortable trying to bring down the IOP a couple of millimeters down. But like Manoj suggested, DVT is warranted. We may find a pressure of 25 sometime. DVT is still warranted.
Sometimes, like in such a scenario where we have these depressed paracentral scotoma in the 24-2, we sometimes ignore it and might be learning curve. So in such a scenario, whenever you are dealing with an NTG, it is always advisable to go ahead and do a 10-2 field. Without doing a 10-2 field, we cannot rule out a patient of NTG. And this, since the RNFL defects are more closer to fixation, you get a denser and deeper scotoma loss in 10-2 field.
You can do a 24-2C also.
Central, yeah. Yeah.
No, I would prefer a 10-2 because we are really concentrating on it. We already got the 24-2 done.
And we went ahead and did a OCT RNFL, and the heat map shows a well-defined RNFL loss and even picks up a superior RNFL, which is not seen very clearly in the red optic disc fundus image. And then the RNFL thickness, if we look at, the more importance is the variation in the right eye and the left eye, the amount of distortance. And so this brings us to how to proceed with the case. What all do we have to ask the history, and what all do we need to investigate the patient? When we have a patient with a disc hemorrhage and a well-defined wedge loss, RNFL loss, which is picked up in OCT. What do we have as a questionnaire to go ahead and work up a patient of NTG? No, right eye is essentially normal. Right eye is essentially normal.
Not very unusual to
Yes,
have.
sir.
It's
Most
quite,
often we see disc hemorrhage in unilateral eye, like one eye. Yes.
not very uncommon.
10
to
years
see.
later, you'll get it in the other eye. 10 years later, you'll get it in the other eye.
Okay.
Is he obese and has some sleep disturbance?
Great. So,
Does he snore?
she doesn't know it. The husband knows. The husband,
should ask.
yes, the husband complains. So we did a polysomnography test. Her essentially the office diurnal variation was within normal limits, and if you look at the polysomnography, there are few indices which says the apnea hypopnea index. Then we have the respiratory index, or also called as a risk indicator, which was significantly high. The usual recommended values are somewhere between less than 5 per hour, but her values were in the range of 10.5, and the oxygen desaturation index was 5.3. So a list of questionnaire checklist when you deal with a case of normal tension glaucoma would be to ask for, and you want to rule out anything like a one-time damage, whether this was a one-time damage because of past history of a steroid use, a trauma, healed uveitis, systemic antihypertension, any history of migraine or Raynaud's phenomenon, significant blood loss in the past, anemia or blood transfusion, whether the patient practices yoga, especially pranayam, breath holding exercises, and like we discussed with the previous case, whether there is a significant amount of water consumption at one shot, and then obstructive sleep apnea. This is the workup checklist that would be one of the take clinic message from this presentation. We need to do a diurnal variation because one-time IOP may not give you the correct evaluation. Then the blood pressure analysis, a complete hemogram. Very close finding will you see it in toxic neuropathy or even nutritional amblyopias, nutritional neuropathy, more centrally involving in the HFA. So you need to do a serum homocysteine levels and vitamin B12 and folate levels, then serum lipid profile, a ECG or a 2D echocardiography to see any carotid artery occlusion or any decreased ocular perfusion, sleep lab referral to do a polysomnography. There is a role of neuroimaging and MRI. How to assess progression in NTG? Like we already discussed, fundus photo and a visual field loss or increased disc cupping, and a very peculiar finding about optic nerve head hemorrhage or a Drans hemorrhage is that it appears, and we all know that it disappears by 3 months. And a reappearance of a disc hemorrhage, which was already there and which had disappeared, indicates that your basic pathology is not under control. You need to take care of that. When do we ask for a neurological workup in such case? Comments from the panel, please. Leaving this aside, when we have a case of a normal tension glaucoma, do we usually do a neuroimaging, or when do you like to do a neuroimaging?
I don't see a reason for neuroimaging in this case.
You need
Less than 50. The fields not
Okay.
corresponding.
Okay, yeah.
profound pallor,
Yes,
unilateral profound
yes,
pallor.
yes. If there is a marked asymmetry or unilateral optic nerve involvement, unexplained visual acuity loss, color vision defects or in the absence of visual field deficits, not corresponding or out of proportion to the optic nerve damage, vertically aligned visual field defects, and atypical neurological symptoms for glaucoma. And optic nerve pallor, as mentioned, in excess of cupping. These are the few times when you do a neurological workup. And role of CCT. It can mark an accurate reading of IOP, making us to treat a condition that may not really exist. And IOP value should always be interpreted with respect to CCT values. Yeah. Yeah, so these are my take clinic messages. CCT plays a major role, thorough history to rule out any systemic cause.
One question I have is,
Yes, sir.
if you do a polysomnography, you find this.
Yes.
Okay, now imagine because of these findings, the patient is advised to use a CPAP, or
CPAP,
something like
yeah,
that.
yeah.
Is there any evidence that use of the CPAP actually kind of
Regresses
stabilizes the glaucoma?
Yes, yes, definitely yes. It's
But there is
very well established. There are so many studies are there now.
Most of the studies say that the sleep apnea treatment kind of helps you in reducing the risk of heart failure, but not so much in glaucoma.
In glaucoma, actually, definitely it is yes, especially in NTG cases, the progression is almost not there, provided that it is only because of
Sleep
the
apnea.
sleep apnea.
Yeah.
So we have to understand that part of it. Saying that all sleep apneas can it cause progression of glaucoma may not be true, but the sleep apneas are, if it is a definitive cause, once you treat, definitely there is a progression is much reduced. That is evidence
If they
based.
repeat a polysomnography once they start treatment, do these values, the carb values, not come down? I mean, what is,
CPAP is kind of permanent.
no, that is there.
Yeah.
But once you start using
I've
CPAP,
never,
6 months, 1 year later,
I've never got that done.
I'm using it myself, doing it.
No, one,
please get
see,
it done.
only thing is they are symptomatically definitely better in the daytime.
so
That
that's
is
not
the,
presumptive.
Followed up.
yeah.
You are symptomatically better.
Uh,
Look at
No, they asked to do
No,
it after
a
6
long
months
period of
after
time.
No, I don't think the
If-
respiratory medicine people repeat it actually. They
If
just,
I can intervene,
like you said.
Yeah.
we did have cases at LVPI and under Dr. Sirisha's care. We have seen patients' parameters improving, the AHI and RI factors. This patient lives abroad, so I couldn't follow up this patient. Maybe the next time when she comes, I'll get a.
But that is a very valid question to ask. Whether does it really improve the patient's entire condition? I haven't done, but only most of us do to find out whether they have a sleep apnea or not, and then we tell them to go for a CPAP.
Yeah.
So thank you,
Like Saket
Mahesh.
said, there are very few cases where 100% you can pinpoint that this
It is
glaucoma is due to
sleep
sleep
apnea. Yeah.
And also many times we don't know whether we are able to really establish a cause for the NTG. Sometimes even the sleeping with the pillow pressed on the eye itself is a cause. So, Mahesh, is it really you feel the CCT plays a major role in NTG?
We cannot
Because,
give a correlated value that for 20 microns this much is the IOP value, but we just need to take in consideration, especially when we are dealing with a patient with post-LASIK where the IOP, where the thickness has been thinned out.
Yeah. So I feel in a very established glaucomas,
Yes.
the CCT may not be the real factor that you want to really see and treat based on that. The CCT helps us to understand whether this patient will progress a little bit faster than the other patients.
Okay.
In a OHT, whether you want to treat OHT or not, when there is a confusion, the CCT probably helps you out.
Yes.
Same way in the glaucoma suspects. But in a very well-established glaucomas, I don't think you have to really see the CCT. Say, for example, patient in a POAG has 22
Okay.
and CCT is 620.
Ah.
Will you not treat? So CCT has a role, but not in the very well-established glaucomas. That is what we need to understand.
In NTG, the other issue is it's usually a step ladder progression. You'll be okay for 5-10 years and then one step. So there is no way that we can say we've dealt with the risk factor and we've stopped progression.
Yeah.
It may happen 15 years down the line, next step.
Completely accept that, because NTG can be non-progressive for a period of time, and then suddenly it can be progressive. The patient gets treated for his cardiac ailment, and then suddenly it becomes very stable. And then whenever again he has another block, again it just goes up. So following up the NTG is very critical. It is not just that, okay, one time and then you just forget about it. It is not so. So that is what we need to understand. Thank you, Mahesh.
Thank you, sir.
Sir, if you find it is due to something else, do you start treatment even then or treat the primary?
Madam, whenever you find a cause, any disease for that matter, we always try to treat the cause first, then the symptom or the sign.
So no need for AGM and that.
No,
not that way.
I would disagree, because CNTGS has clearly said even whatever be the situation, reduction of IOP still does help. So you try.
also treat the
You have to treat the cause, but it doesn't mean that you don't treat the as such glaucoma.
അല്ലല്ല പക്ഷേ there is something CNTG 65% of the patients had no progression. only 1/3 of the patients had progression over 7 years. But if you take the CNTG data alone, the default option should be to not treat with anti-glaucoma medication, number one. The second thing is the CNTG, the study itself, only took in really advanced NTGs. They didn't take the garden variety, only the ones with severe documented progression or the ones which were quite severe in nature. So a garden variety mild NTG by default, I think we should not probably consider treatment, considering the fact that 2/3 will not progress at least for 7 years. But again, it will be
No,
individual.
that will take audience for a little different viewpoint. At this point in time, we'll have to make sure that we treat the NTG, but identifying who is non-progressors takes over a period of time. So we have to be very cautious whenever, see, the studies will show that 2/3 didn't progress, but which 2/3 we don't know. So we have to understand that part also. So sometimes audience will take home as a message saying that NTGs we don't have to really treat. So that is not the message we are conveying here, but we need to understand many of the NTGs may not really progress, but we have to see the follow-up and decide on the factor whether you really want to treat them at that point in time than at the first time diagnosis itself. If you don't treat at the first time of diagnosis, then that is not the ideal way to go with.
Another thing is in our setup, we may lose the patient also because they'll go behind the cause, and if it's a major cause, they'll go ahead with this and won't come back. By the time they come back, referred from because we have a patient who had a hemorrhage and was sent, was actually a multiple myeloma case. Patient went to RCC and then came back after a very long time, and by then the GON had significantly progressed.
Right. Okay. Thank you. Namita. Yeah. Nimita. Sorry. Only we remember actors' names, actress names.
Good morning. I'm presenting a case of a 65-year-old male who came with a gradual loss of vision since 3 months, and it had increased since past 1 month. And he was an hypertensive on medication with a strong family history. And he was started previously on timolol eye drops, that is for three years ago, but he had discontinued. So on examination, his best corrected visual acuity, right eye was 618 and left eye was 612. IOP, it was 42, right eye, left eye was 20. CCT was 554 and left eye was 556. And AC was shallow and gonio was closed. And fundus showed 0.9 cupping with superior and inferior rim loss, and left eye showed 0.8 cupping with NRR was pink in left eye. Then a provisional diagnosis of primary angle closure glaucoma was made. He underwent YAG peripheral iridotomy, and following which he was evaluated, where OCT showed severe glaucomatous changes in right eye, and left eye there was damage also seen. HFA right eye there was severe damage, whereas left eye there was moderate damage. So he was later on he was on timolol and brimonidine eye drops in both eye, and as his IOP in right eye was uncontrolled, he had underwent TRAB with mitomycin C in right eye, and vision right eye was 624 and IOP was 18 post trabeculectomy. After 1 month, he had a vascularized bleb, for which 5FU injection was done. The IOP in the right eye at 1 month it was around 26, whereas up to 6 months. He was on constant follow-up, and he had an IOP in his last visit. It was 22 in the right eye, and he was on bimatoprost in both eye, timolet in both eye, and ripasodil in right eye. Whereas in left eye, it was 18. Vision right eye was 624, and left eye was 69. After which he had lost follow-up. In between, he had underwent micropulse laser, that is from outside. And after 10 months, he had come again with an IOP 50. And left eye, it was 16. So right now his diagnosis is right eye uncontrolled advanced glaucoma, post-trabeculectomy, post-micropulse laser status. And left eye he had a primary angle closure glaucoma, post-YAG peripheral laser iridotomy, and it was medically controlled. So ultimately, we did an RD valve for him, and initially he had initially the scleral patch. This is the scleral patch graft is well, and the conjunctiva was well. A post AC was formed, and there was a ripcord suture. And post-op 1 month right eye vision was 618. Coming to his IOP part in the right eye, that was it was 30, and he had at 2 months he had an epithelial defect with corneal edema with vision drop, following which we had shifted him to preservative-free drops, and after his epithelial edema resolved, his ripcord suture was removed. Then after the ripcord suture was removed, the IOP was initially 18, then it dipped down to dipped down to 10, sorry, and then he developed a CD. Then after that, it shot up to 40, and Pilo was added. Then so constantly, he at the end of 8 months, he had a high IOP, and at 1 year, blood needling was done. Right eye, his vision was 612, whereas left eye 66, and IOP right eye was 32, and left eye was 16. He was on anti-glaucoma medications, that is bimatoprost, brimonidine, and brinzolamide eye drops. So this is a picture where he had developed a cystic bleb. In the left eye, he was fairly stable. That is, his IOP was 6.6, and in 2024 we had repeated his fields. Showed it was fairly stable fields. So a left eye primary angle closure glaucoma post YAG peripheral laser iridotomy with controlled on anti-glaucoma medications. So in 2021, he had underwent a trabeculectomy. In 2000, after 1 month, he had an injection 5-FU. In 2022, he had underwent a micropulse laser. 2023, he underwent RD valve. And after 2 months, supramid suture removal and post blood needling also was done. So it's a right eye refractory glaucoma post TRAB, post MP laser, post RD valve. So my question is how to with IOP high.
Okay.
So how to control next?
The one thing is little unusual is when you have a very high IOP in an angle closure, when you do the trap, usually it doesn't go for a failure. That is kind of a dictum, I can say. But when you have a too excessive scar tissue, then possibly yes. But that is quite unusual to have something like that. Second thing is the micropulse laser in majority of the cases might go for a failure, especially when you have a very high scar tissue formation in the trabeculectomy area where you probably may not have, could not have done it properly also. That is second thing. Post RD valve failure, again, we can say only the scar tissue formation. Again, unusual finding for me is cyst formation in RD valve, which is very unusual to see. Not like in Ahmed valve, we used to see that almost in every patient, but in RD valve. So this definitely indicates the patient has a very, very high chance for getting into more scar tissue formation. So what next is, anyway, have used almost all medications as such now. It doesn't mean that.
Cynical closure.
So it doesn't mean that Pilo will work in every given patient. No. Just adding a medication, you cannot just say that it is going to work probably. The next option for me is, it is not that we are just going to lose hope. That No. Aspirating
No,
the
no,
cyst
that,
is
that doesn't
only
make sense. That doesn't
only
make
for the
sense.
fun of it. You can just do that, but no. Just you have to understand, aspirating the cyst is just for your happiness, but it
If pseudophakic, the picture. What I would suggest is if the patient is willing for one more surgery, this cyst is actually the Tenon cyst. So if you aspirate, you're going to reduce the pressure right inside. So you have established that the tube is patent. That's good. What I would suggest is stop the bimetoprost, wait for 1 month, maybe on steroids, go in and excise the capsule on this top side and close again and come out. Carefully dissect the conjunctiva off. You'll have a nice cyst there. Just take off a huge piece from on top, close it back.
yeah. So
Same,
there is
same.
So in this there is no one right way to go. If you can really see that by anterior segmentosity, if you can really track the tube, if the tube is already occluded someplace, we can really, anterior I can track the tube closures.
So in the aspiration, it collapsed. So the tube is patent.
Oh, okay. Okay, so,
Proved it luckily.
yeah. That's what I was trying to say. There is no one right way to go with this patient. You can always go with the inferior. Also, you can go with one more tube in case if nothing goes well. Like the simplest thing is just go to the cystic space that you can cut and remove, and see how much you can really reduce it. If it doesn't work, then we have to go with one more. So one of my patients has 2 tubes, 3 traps, and cyclodiode. Everything has been done, but for the past 20 years, still she has some useful vision to see. So we don't have to really lose hope of just leaving it as it is. So it's a challenging case, definitely. It is not that, but whenever you see a very high IOP, don't try to close the wound too tight. It doesn't mean that, okay, patient has a high IOP, I want to close in an angle closure glaucoma, I want to put a tight suture. Don't do that. Just do your retin trap properly. So one simple thing is, many of them will just try to close it too tight. So that will cause more scar tissue formation, and then there is a sequelae for that. So don't try to do unnecessary things. But we are all mentally kind of tuned to that. High IOP, they may have an expulsive hemorrhage, so I want to put tight suture. Don't do that. Just do your routine proper trap.
Sir, since Adi, also formed a cyst, if at all we have to do another implant, so do we still go ahead with do an Adi, or we'll do an AGV?
It depends upon the comfort of the surgeon, but for me, definitely I will go with one more RD than going with the AGV, because with RD itself, when you have such a large cyst,
yes.
I won't definitely go
You'll
with an
expect a
AGV as
bigger
a
one with
second
AGV
choice.
also.
Though it may,
Location, would it make a difference?
Yes.
Inferior, would you err more for an Ahmed where compared to an Adi?
most of my Ahmeds I have done initially is only in the inferior zone. Yeah.
Is it not better to have an inferior Ahmed and a superior Adi?
I'm talking about the inferior RD, I'm saying.
Or at Adi 250 inferiorly.
Yeah.
The smaller fellow.
Yeah,
It's
now we have the
doesn't go
250, but I used to do 350 inferiorly only most of the times. When Paul Palmer came for us to teach, that time we were doing only inferiorly. We didn't do anything in the superior. Most of the cases are still working, but many of them, of course, we have to really remove because the tube touch and then corneal damage.
So one difficulty that we felt while assisting Dr. Sirisha was that since superotemporal you have already done Adi and you have made the muscles loose, you would have had a fibrosis of the superior rectus and the lateral rectus. So if you want to again do infrotemporal, the lateral rectus would have fibrous. You might not get a space to put it.
Infronasal.
Infronasal, yes.
Infronasal, yeah.
Thank you, sir.
Thank you.
Who is our, yeah. But one thing is, don't lose hope of treating the patient. Try to manage them.
Keep on treating.
Yeah. At one stage, they'll go to the next hospital. You can be really relieved of that.
Glad Trivandrum is far from there.
A very good morning to all of you. So I'm presenting an unusual case which I face a lot of difficulty in diagnosis. So a 56-year-old female who was working in the Middle East presented in August 2024. She gave a history of dengue fever 2 months back, for which she was hospitalized and treated. After 1 week of getting discharged from the hospital, she developed pain, redness, and blurring of vision of both eyes. She consulted an ophthalmologist there and was told to have inflammation in both eyes, for which she was started on steroid eye drops. 3 days later, she developed severe headache and blurring of vision. When she went back, she was told to have raised intraocular pressure. And when the patient came to me, she was on Zalatin, Cosopt, and loteprednol eye drops. So vision was 6 in N6. Conjunctiva, there was no congestion. There were a lot of pigments over the endothelium. Anterior chamber was grade 1 shallow with pigments all over the anterior chamber. Pupil showed extensive posterior synechia with iris bombay, early cataractous changes with pigments over the anterior lens capsule. Disc was normal, intraocular pressure was 40 and 42. Gonoscopy showed 360-degree appositional closure. So I thought of a uveitic pupillary block, did a Yaga iridotomy in both eyes. Thinking of a uveitic etiology, I stopped Zalatin, started the patient on Compigan, dosulamide, prednisolone, and atropine eye drops together with oral acetazolamide. So reviewed the patient after 5 days. A uvea clinic opinion was taken. They were of the opinion that there's not much of inflammation. It was more of pigments. Now I was happy the intraocular pressure had come down to 23. So I continued the topical medication and stopped acetazolamide. So this was her anterior segment picture. Reviewed the patient after a week. Now the intraocular pressure has gone back to 40 millimeters. So again, I was doubtful what was happening. Initially, I thought it was a pupillary block and did a PI, and I thought my PI worked and the intraocular pressure had come down. Now again, when the acetazolamide was stopped, again the intraocular pressure has gone back to 40 millimeters. There were a lot of pigments in the anterior chamber and all over the anterior lens capsule as well. Gonio showed open angles now with lot of pigments in the trabecular meshwork. The disc was essentially normal. So now I was thinking whether it's a steroid response. So since the uvea opinion was that there is not much of active inflammation, I stopped steroids, added NSAIDs and Zalatin, and also explained the need for a surgical intervention, but the patient was quite unwilling since her vacation was getting over. Reviewed the patient after a week. Intraocular pressure was 26 and 28, and the patient was on Zalatin, Compigan, Dosox, and epiphenolic eye drops. So I didn't have a diagnosis. I thought whether it's a dengue-related uveitis, a drug-induced angle closure. While this case I was dealing with, then only John had posted a case of baddie in the GSI group. So I was thinking of that also, whether it's a steroid response. So dengue, mostly the ocular manifestation is a subconjunctival hemorrhage, and uveitis, whatever has been reported, is mostly posterior uveitis with retinal vasculitis as the most common presentation. 98% was posterior uveitis with one panuveitis. This was a paper from Singapore. Then regarding BID, it is acute onset of depigmentation of iris, and the pigments blocks the trabecular meshwork, giving rise to raised intraocular pressure. The etiology, they tell systemic antimicrobials like moxifloxacin and antecedent viral infections can be the cause. So the glaucoma is refractory to medical management and filtration surgery has been suggested. So my questions are regarding the diagnosis, how to investigate, when to decide on a surgical intervention, and also the surgical intervention of choice.
Later, one question. Was that lotepred or moxi-lotepred combination?
No, it was loteprednol.
Only.
Only.
I've seen this happen with topical moxi also.
Yeah, in the literature they are telling even topical moxi can cause this bi.
So, presently the patient is here or he has gone back to Dubai?
Patient went back. I was happy.
That is exactly I was telling you earlier also.
I was happy.
Yeah,
Yeah.
there is.
See, second
Yeah.
problem after the PI is an open angle pigment glaucoma.
So, one thing is we are sure that it is going to be only a secondary glaucoma. Now it is going to be how we really want to treat the patient. Then
That is why, sir. Actually, when I asked to my go-to person, Dr. Moidin, he advised for a angle surgery. So I was quite doubtful whether.
for this patient, I am not sure whether I will go for an angle surgery because it is already angle is completely patchy with so much of pigments in it. With the angle surgery, Moidin may be good, but I am not sure whether I am good. But maybe a GAT, if you want to go
That
with.
is what what he was suggesting.
For Moidin, only GAT. But for angle surgery, there are other MAGS procedures also there. But with so much of a pigmentation, you're going with a GAT, I'm not sure whether it will work. But I'm not good at doing the GAT still. So I won't comment on that. But for me, whatever is best works in your hand, we have to go with it rather than trying out and then again causing more problems. But for me, it will be like the first choice is going to be a trap, then going in for angle surgeries.
And since it was a bilateral condition, trap,
Sequentially.
Yeah. See, you can go with whichever eye has more damage as the first, or IOP, whichever the eye has a higher IOPs. So,
I'll take it.
You don't want to wait for some time.
see, with so much of medications, disc is fairly normal.
Optic disc is good.
Yeah.
Put the patient on treatment. Dengue is one disease which causes vague manifestations.
How many days,
Some
doctor,
of
now?
them-
How many days now?
It was 3 months after dengue.
No, the entire period now, with the high IOP till now, how much
3
is
months,
that?
3 months.
3
While
months.
she came to me, it was 3 months.
So he had dengue before that, no?
She had dengue 2 months before coming to me, and she developed this clinical picture 1 week after getting discharged
So
from
I'll
the
just make it little simple for you. The high
How long
IOP you
has
have
the-
seen when? Which month you have seen?
I saw her in August, and the incident was in May.
Okay. May till now, right? Now December, almost December. So it's almost 6 months till the IOPs are still running higher. But one thing what we need to understand is when the IOPs are higher, even if you don't see the disc changes, the disc changes will come only after 8 to 12 weeks. So we have to understand that once the IOP comes down and then do the evaluation properly, then you will understand that there is a significant amount of damage will be there. So IOP of so high running for quite some time, I would definitely intervene. But is that I change a medication to see the patient how they behave is a choice that we have to
Last
take.
IOP was 27.
27.
Two things here. One, the IOP is going in the range of 40s. You're not just running the risk of glaucoma, you're running the risk of a CRVO, CRAO, that sort of stuff. That can happen anytime. Other thing is this, I mean, I've seen quite a few bait, baddie and all after IOLs, a few with just topical Moxie, and the typical topical Moxie, there is Moxie lotepred combination or Moxie Dexa combination given for uveitis, where it's too frequent, not 3 times a day. And the other thing is, once that process starts, it takes about 1 year for the pigment release to stop. And the iris is going to be stuck in a mid-dilate position, atrophic, very bad shape. So you need something that is allowing the pigment to get out, which is only trap. And I've done about 10 traps for this indication alone, and all of them in the post-op period, you can see the trap flap, scleral flap marked out with pigment, that rectangle, I use a rectangle flap, so a rectangle pigment, and the pigment stops around, the further pigmentation stops around 8-9 months, and this is a 1 year we have to treat glaucoma. So I will go for trap.
Yeah, usually it will look like as though there is a necrosis around the trap area. The bleb area, it will look like so much of pigmentation. Yeah, the entire area will be with a lot of pigmentations. I think we have one more presentation. Thank you, doctor. Thank you so much. Yeah, please. We'll have a quick presentation because only 5 minutes to go.
Good morning. After 4 cases with lot of diagnostic dilemmas, we'll present a simple case with a little bit of a more colorful presentation. So when trauma leaves a lasting impression, myself is Dr. Manju.
Slides, please. Slides, please. If there are slides.
Okay. Good morning. So when trauma leaves a lasting impression, so a 26-year-old male patient with a history of injury with a stone to the left eye 2 days back came with pain, redness and defective vision left eye. The positive findings, the left eye was 2 mm of hyphema, sluggishly reacting pupil and phacodonosis. The patient was treated in the general OPD. Then the vision was 636 N8. IOP was recorded with NCT was 18 and the fundus was hazy and the patient was treated with prednisolone eye drops, hometropine, nepafinac and headed elevation and bed rest. And the patient was referred to us after 2 weeks to the glaucoma clinic telling that there is a rise in IOP. On the examination, at that time IAC was quiet, pupil was sluggishly reacting, lens was clear even though there was a mild phacodonosis. And vision was 6 parts N8. IOP was 32 with applanation tonometry and fundus evaluation revealed was within normal limits. So this was the video. There is a minimal, very minimal phacodonosis on a clear lens. And as you can see, there is a widening of the ciliary body band, more than 270 degrees of angle recession, only few areas that was spared. And fundus examination, this was normal. OCT, RNFL was within normal limit. So there was not much of a diagnostic dilemma. So angular recession glaucoma diagnosis was confirmed. So the patient was treated with dorzolamide timolol, a fixed drug combination of dorzolamide timolol eye drops 2 times a day, and Diamox was given for 5 days. So after 10 days, the patient's vision was 6 and 6, IOP was 18, and the patient is under follow-up. Angle recession glaucoma is a secondary open angle glaucoma associated with ocular trauma, and recession of the angle was can be revealed on gonioscopy in most of the cases, and greater the number of clock hours of angle recession, greater likelihood of developing glaucoma. And these are the causes of IOP rise. This is one thing. Last one was when I was hyaline membrane can grow across the tibicular meshwork that was mentioned in the below mentioned study. So take home messages are thorough history and examination of prior ocular trauma and gonioscopy is important. You should previously inform the patient that there is a long-term monitoring that is essential. Need to rule out other causes of trauma. First, we can start with the aqueous suppressant, and if possible, we can change to prostaglandin analogs because it can open up the other pathways. Surgery if needed, and multidisciplinary approaches of associated injuries is needed. I took up this case because I had few queries, which was like, when some patients are referred from the periphery, if they have hyphema, they are like prophylactically started on anti-glaucoma medication. There is no recorded IOP rise, but prophylactic started on anti-glaucoma medication. And a few cases, there is a more than 180 degree of angle recession, and there is no raised IOP recorded, but started on anti-glaucoma medication. And one patient was started on aqueous suppressant, and after 2 months, IOP was like 21, 22. So I thought of changing into prostaglandin because the more chance of IOP decrease, UV clear outflow. But again, the patient had some IC reaction, photophobia and all, and again had to change to aqueous suppressant. And if this patient was not having any cataract, but if this patient was having a cataract with phacodonosis and with raised IOP, should we post him for a combined surgery or cataract surgery alone? These are few questions I have.
Quick comments from Dr. Sai, Thomas, and all of you. Quick comments so that I think
this was almost clear lens, very minimal phacodonosis. I wouldn't touch this lens at this point of time.
No,
and
this case, like
in case you require, do you require a combined surgery? The glaucoma is well controlled with a single drug or a single aqueous suppressant. I would still go ahead with just a cataract surgery because cataract surgery itself may not be very easy. You may have to put in capsule hooks and CTR and maybe sutured CTRs and things like that. So I wouldn't probably combine it with a trab anyway.
So in angle recession, whenever you see the angle recession with the very low IOP levels are the patients who will go for a possible high IOPs later on. That is one indication you should take. Second thing is the patient can have glaucoma even after 10 years of injury. So we have to just keep a follow-up of these patients and then manage them properly. So these are the two important messages I can give you from angle recession. Any other things you want to add?
Prophylactic treatment, I would say no. Unless you have a documented IOP rise, which can happen, as Satin said, even 10 years down the line, the fibrosis and the hyaline membrane and all can keep forming, and it can raise the IOP. So we have to keep the patient on follow-up initially very closely, and then later on, maybe at least once a year, we need to see the patient.
The thing is, some of the patients are started on anti-glaucoma medication from
Stop it.
periphery.
Stop it and see if it
that's
goes
why.
up.
Whether to stop it or not.
Stop it and see during the washout period if it goes off.
Yes.
If it's a beta blocker or a alpha agonist, you're looking at following up the patient 3 months for that purpose alone. 3 weeks, 6 weeks, and 12 weeks is what I tell them. Prostaglandin analogs and dorzolamide, 1 week down the line, you know what's happening. As far as the baseline IOP is concerned, stop it and see it.
Okay.
Thank you so much.
Thank you, sir.
And once again, because there's